Hello and welcome to the Point of Care podcast. Today's topic is persistent inpatient fevers. The general differential diagnosis for persistent fevers in the hospital despite antibiotics include wrong bug, wrong drug, wrong process, no source control, and not enough time. Let's take them one at a time. First is wrong bug. When we give antibiotics, we usually assume that the fevers are due to a bacterial etiology. But after some time, you should also consider viruses including CMV, EBV, HBV, and HCV, fungi like Candida, Aspergillus, or PJP, and atypical infections like those that are tick-borne or tuberculosis. In neutropenic fever, if the patient's been fevering for 4 to 7 days despite broad-spectrum antibiotics, it might be reasonable to broaden to fungal coverage. In those cases, voriconazole or posaconazole are preferred. Fluconazole is saved for known Candida since it doesn't cover endemic mycoses or Aspergillus. Some factors that might push you towards broadening to fungal coverage include a positive beta-D-glucan if the patient is experiencing severe sepsis, if a CT of their lungs shows GGOs and/or nodules, a prolonged ANC less than 500, or the use of TPN, though recent literature suggests that TPN use is not an increased risk of infection. Though it's not part of the guidelines, a common misstep I've seen is not covering for atypical infections like mycoplasma. This happens sometimes when a patient comes in really sick and septic appearing, so gets your typical broad-spectrum antibiotics with vancomycin. Only a few days later does someone on the team bring up that, though we have broad antibiotics on board, it has some gaps, like azithromycin or doxy. If you really suspect an infectious process, you should go back to the drawing board and complete a full ID and social intake history. Things you should ask about include travel, both domestically and internationally, where they went, how long they were there, what they did when they were there, food and water that they consumed, whether or not they took immunizations or prophylactic medicines before going. Work exposures, including if the patient is homeless or works with the homeless population, served in the military, or was imprisoned. Also ask about drug use, including alcohol, tobacco, recreational, and IV drugs. The patient's sexual history, including the number and genders of their partners over the last 12 months. Their practices, including genital, anal, oral sex, as well as protection they've used, whether they've been tested for STIs in the past, and if they've been treated. Hobbies that might put them at risk include gardening, water sports, or going into the outdoors. Their dietary history, including the consumption of raw or undercooked meats, unpasteurized milk, and animal exposure, including pets, zoos, wildlife, or other like livestock. The next on the differential is the wrong drug. This is most commonly due to multi-drug resistant organisms. Some examples of these in common treatments include extended spectrum beta-lactamase GNRs, in which case you would do a carbapenem, vanc-resistant enterococcus, in which case you treat with daptomycin or linezolid, a carbapenem-resistant Pseudomonas, and there's many options for that, and then the Candida krusei, which you can treat with voriconazole. It can be really intimidating to reach out for these big guns, since many don't actually have experience using them. So if you think you have an MDRO, or if the cultures show that you do, you should consult ID for advice on the best agent and the best antibiotic stewardship. The next on the differential is wrong process, meaning it's not infectious. There are many things other than infections that can cause fever, especially in cancer patients. Just to name a few, these include drug fever, malignancy, a transfusion reaction, thrombophlebitis, and autoimmune disease. In neutropenic fever, it's particularly unfair that cancer itself, as well as the needed transfusions, clots, which all cancer patients are susceptible to, and the antibiotics that are meant to address the fevers in the first place can all be the culprit of a patient's fevers. Some common drugs that can cause fevers include antibiotics, such as penicillins and cephalosporins, which are some of the most common antibiotics you use in the hospital, anti-epileptics, including phenytoin and carbamazepine, anti-neoplastics, and allopurinol, as well as Precedex. If the patient fits more into the fever of unknown origin bucket, it's helpful to complete a full room review of systems. We have a point-of-care medicine template that can help guide your HPIN exam, and we won't go through that in detail now. Fever of unknown origin falls into its own separate diagnostic schema. There's also a point-of-care medicine template for fever of unknown origin as well. The next thing on the differential includes no source control, and this is a common reason for an infectious cause of a fever of unknown origin or persistent fever in the hospital. Imaging is the most common thing we can do that'll helpfully localize the source. In particular, you should be thinking about endocarditis, especially in those with bacteremia, a central line associated bloodstream infection, especially in those with ports or indwelling catheters, osteomyelitis, and a liver or abdominal abscess. You should get a TTE to look for endocarditis only when you've seen that the patient has positive blood cultures. The workup and management of endocarditis is its own beast saved for another time. There's also a point-of-care medicine template for that as well. You should be aware that there's such a thing as blood culture negative endocarditis, and it's usually due to getting antibiotics before you draw your blood cultures. Other causes, though, include Coxiella and Bartonella. The last thing on the differential diagnosis is that you just haven't treated for enough time. Even if you've given the right treatment, fevers can last for a few days, and this is usually true for diseases that are hard to treat and require a prolonged course of antibiotics, like endocarditis or osteomyelitis. Fevers caused by a virus can also last for several days as the body goes through its natural process. It can be challenging in these situations to sit on your hands, but it's often the right choice if the patient is stable. You should also be mindful that fever is secondary to a new infection from an iatrogenic spread of a respiratory virus like COVID in the hospital. If it seems new or the patient is developing URI symptoms, send off a repeat RVP. In general, after you've thought through this very broad schema, the decision to broaden antibiotics or to go digging for a source is dependent on your clinical judgment, the patient's clinical status, and their overall risk of decompensation. It's a gray area in medicine, and there's absolutely no easy answer. That's all for this episode. Check out pointofcaremedicine.com to see the templates we discussed in this episode, as well as pearls, literature, and links to other resources.